Hi, Josie. My name is Taylor, and I'm going to be your nurse today. This must be Johnny. Can you tell me what's going on?
Yeah, hi Taylor. Yeah, I'm just really concerned. Johnny, my son, has just not been eating, and he just looks really pale, and he's not having a bowel movement like he normally does, and it just smells really like foul and just off, and I'm just really concerned. Um,
Okay.
Also, he's been vomiting a little bit, and his stomach is protruded. Um, do you have any suggestions on what's going on?
How long has this been happening?
For several weeks. But I feel like it's just getting worse right now.
Okay. And when he vomits, is that pretty directly after he's eating food, or is it maybe a change in food that you're feeding him? Are you doing anything different in terms of diet?
No, it's been the same diet, and it's pretty much right after he eats. Yeah, and he just looks really pale. He's not putting on weight. He's he seems smaller than my other kid I had at this age, and I'm just really concerned.
Yeah, that is concerning as a parent. So how long have you noticed the protruding of the abdomen?
Um, I mean, probably the last 2 weeks, it's been pretty noticeable, and I like kind of feel his stomach, and it's almost like I can feel something. Um, yeah.
All right, and then you said when he does go to the bathroom, it's foul smelling,
hmm
and that's when he passes stool.
Yeah,
Okay,
which has been rare lately, but when he does, it's
okay.
not. Yeah.
So he's constipated, foul smelling. There's an abdominal mass, and he keeps vomiting after he eats. All right, so let's take him back and do an assessment. And I think we'll draw some labs, blood work to see if we can see what's going on. So we can just go in this room over here and we can do our assessment and you can come with and yeah, let's see what's going on.
Okay.
All right, Josie. So I just spoke to the doctor about the assessment and we're still waiting on those labs to come back. So he has the abdominal mass and that is fecal matter that's kind of stuck. And he has a few ideas of what's going on. One of them is he's suspecting that it could be Hirschsprung's disease. But to actually confirm that diagnosis, we have to do a rectal biopsy, which we can actually do today. So the gastrointestinologist will be the one to perform that. And this is just your child will lie on his side and they will insert into his rectum and grab some biopsy of the intestine, but this won't hurt because there's really no nerves down there to feel. So it might be a little uncomfortable, but pain wise, it should be okay. So we will do that right now, and then we'll see you in a couple of days to confirm that with the doctor.
Okay. Thank you.
Came in and talked about the diagnosis of Hirschsprung's disease.
Yeah, I don't know how I'm doing. I'm just, worried as moms are. But he just used a lot of big words, and I don't know, like, could you explain to me again, like, the disease process? I'm just a little overwhelmed right now. I couldn't really think.
Yeah, for sure. I can definitely do that for you. So, Hirschsprung's disease is a congenital ganglionic megacolon. This means an absence of ganglion cells in the affected areas of the intestine, resulting in the loss of rectosphincter reflex and an abnormal microenvironment of cells of the affected intestine. And those are very big words. To just break it down and simplify it, um, there is a part of the intestine that doesn't have ganglion cells, which means that there's no enteric nervous stimulation. So the colon can't actually, it's not getting receptors to relax. And so when you have peristalsis, I'll just show you. So the colon kind of goes like this, is like moving the fecal matter through. And when it doesn't have ganglion cells, it doesn't have the reflex to be able to relax. So the end of the colon, it's just tight. So the fecal matter cannot move through it because it can't relax. So there's no peristalsis going on, and there's no relaxation. So therefore, stool cannot exit and not be evacuated. And so that's why that abdominal mass was there, because it's just collecting. So that's pretty much the disease process. And one of the complications that can happen with this is enterocolitis, which is inflammation or an infection in the part that the fecal mass builds up, because you have multiplication of the bacterial that's not being released. But your CBC came back and he didn't have elevated white blood cells, so there's no infection going on, so that's good news. So that is the disease process. Do you have any questions about that?
I think you answered most of my questions, but the doctor said that he's gonna have to go into surgery, and I just, like, what are the risks? Like, is that gonna be dangerous?
So with the surgery, it would be more dangerous if it didn't happen, because the fecal mass cannot be evacuated. So there is risks of an obstruction. So surgery is the best option, even though it is scary as a parent. But the surgery, the doctors do their best, and we have really great outcomes. And they just go in and they remove the ganglionic colon, or the area of the colon that doesn't have the ganglion cells. So potentially with this, your child could have a temporary ostomy.
Okay. What does that require for me, like care and time and whatnot?
Yeah, so this is an opening in the abdomen that the colon, the large part, is brought to the outside. And so there will be a bag to collect the fecal matter that is coming out, which will be similar to stool, the thickness of stool. So you'll have to care for it throughout the day. So we empty it when it's about 2/3 full. And we'll teach you this all hands on. But yeah, so there'll be a bag. When it's 2/3 full, you empty it. And then you just replace it, so that you'll be doing that a couple times throughout the day, just making sure to monitoring how full it's getting to empty it, and then monitoring around the stoma to see if there's any infection or redness, any, you know, hints of an infection that are going on. So it's a doable, ostomies are very doable to care for, and this would only be temporary. So that's good news, that because sometimes when it's long-term, it could cause some body image problems, but this is just temporary.
Okay. Are there any red flags I need to look out for?
So for ostomy, if there's redness around the stoma, if there's breakdown of skin, because that can kind of happen because there is an adhesive that sticks to the bag that clamps on. So just skin breakdown, any redness, warmth around the area, that's what we're looking for. And then just, being aware of like symptoms of Johnny, if he's, not feeling so great, that could also hint possible infection.
So, how long should my Johnny be in bed after surgery? Is there a certain time that he can like move after?
Yeah, so after surgery, we'll keep him in bed for about 24 hours, and then we'll be constantly checking his bowel sounds to see if there's any, working peristalsis going on. And yeah, so he'll be in bed for about 24 hours after surgery. And we will just continue to monitor his airway and breathing, assess his vital signs, administer pain medications as needed during that time. And then we'll be assessing the surgical site for any bleeding to make sure there's no complications. And after surgery, Johnny will have a catheter in. We usually do that during surgery. So he'll keep that catheter in for about 24 hours after surgery. And Yep, and then we'll just be providing ostomy care if that is needed, because sometimes it's not needed in surgery. So, but the surgeon will talk over that with you if the ostomy is needed or not. And yeah, just assessing the bowel sounds, making sure everything's going right. But about 24 hours in bed after surgery.
Okay. What should his diet be like after surgery? Is there anything I need to go and get at the store?
So if your child eats solid foods, you want to include high fiber foods, offer whole grains, fruits and vegetables, but you do want to limit white bread and other low fiber foods because a sudden increase in high fiber foods can worsen constipation at the beginning. And high fiber foods should be slowly added to your child's diet as we go on. So it's not the intestine's just not bombarded with all the fiber, just to adapt to it a little bit better. And then you're going to want to increase your child's fluids just to make sure he's adequately hydrated, and that the intestine has proper absorption that it needs to get the stool to pass. But other than that, I think that's kind of no like strict dietary needs after the surgery. We'll probably keep him NPO the first couple hours until there is movement. But other than that, when we start feeding him solid foods, not really a lot to avoid.
Okay, thank you. That helps a lot. So I remember the doctor saying that he might need some bowel prep with an enema. Um, what is that going to look like?
So before the surgery, we're wanting to clear out the fecal matter in the intestines. So an enema consists of inserting a tube 3 to 4 inches in the anus, and then we insert saline, and this helps absorb the fluid and help the fecal matter easily pass out. We want to clean that out so we have a good clear path to resect the part of the colon that has the ganglion cells or that does not have them. And so, yeah, so it's just inserting some saline and trying to get as much fecal matter out as we can.
Okay, thank you. That's helpful. Um, and then you said something about antibiotics. Will that be safe and everything? And
Yeah, so just prior to surgery, the standard is to do an enema, and then we just give some oral antibiotics just to make sure there's no complications with the surgery.
okay. Um, awesome. Well, thank you. That's helpful. Is there anything else I should know before surgery?
So before we schedule the surgery, some things that we want to talk about is, so since with this Hirschsprung's disease going on, he's been constipated, he hasn't been eating well, so he's undernourished. So we want to improve his nutritional status before we do the surgery. So with that, some diet stuff we need to talk about is high protein, high calorie but low fiber diet is what we need to implement. So some proteins that we can add are yogurt, milk, some lentils, but just being aware of the fiber intake that he's having, just to keep that low. So yeah, build up that nutritional status before we go into surgery.
Okay. Sounds good. Is there anything else I need to know or?
I don't think so, unless you have any more questions.
No, thank you, Taylor. I appreciate you taking the time to explain it for me.
Yeah, you're welcome.
I know
And
John will be in good hands.
yes, he will.
Okay, thank you.
All
Bye.
right.